So today I'm going to talk about staging anterolateral LIF with posterior instrumentation. I believe that staging is a very useful strategy in OLIF or in anterolateral surgery, and will kind of try to defend it. And so my talk will be on basically why to stage this surgery, and maybe when it is not going to work, and how one should do it, and the conclusion. So to start with, the most important indication that I feel is aged spine. So we are mostly doing these surgeries in degenerative scoliosis or adult deformity, as we have already been talking. So with aging spine, the problem is that once the age is beyond 80 years, as shown in multiple papers, that with the aged spine, with the increase in time and blood loss, the complication rates, the mortality rates increases in these patients. So that is one of the very big reason I believe that it is a good idea to stage, because once you are doing degenerative scoliosis, you are probably doing it in lateral position when you are putting in cages, and you have to make the patient prone when you are fixing from D10 to S2. So it takes a lot of time, maybe more than 3 hours, 4 hours, and then the problem starts. So we are kind of, here are two cases that in our own experience, this was a 79-year-old lady who had a degen scoli, and we planned to kind of do, she had degenerative spine, canal stenosis at all levels. This was her pre-op X-ray. We planned a one stage fixation in this patient. We did cages, we made the patient prone, but what happened that this patient, the moment we made the patient prone, she developed bradycardia, she developed difficulty, and the blood pressure dropped, and we were not able to, continue with the stage 2 in this patient. So patient was shifted to the ICU, she was kind of again rehabilitated, and after 2 days we were able to do this stage, and a decent correction was achieved. But because of her age, the idea is that because of the age, the patient landed up with a problem. This is her indirect decompression, the anterolateral surgery leading to beautiful indirect decompression in this. This is another patient with a history of the bypass surgery. He was a post-bypass patient. In this also we tried, this was a bedridden person. We initially thought that we will be able to do a single stage, correction of this degenerative scoliosis with the help of cages and fixation. So this was the stage 1. But again, after the stage 1, this patient landed up in a lot of troubles. We were not able to kind of complete the surgery. We had to kind of shift the patient, and the patient was put on a pacemaker. Then we were able to do the stage 2 surgery after 6 months. So this is the result maybe of the stage 2 surgery that we did after 6 months, and these cages, were there for 6 months. They were, the patient was perfectly fine for the first 6 months, and this is how the result after 6 months. So after this, we kind of changed our practice, and the message is that beyond 75 years now we are kind of staging our patients, and we are doing it in 2 stages. So is there any other thing where staging of the procedure can help? So this is a patient where there is a revision already operated, and she is falling. You can see there is adjacent segment degeneration at L3, L4 and L5, S1, and her whole spine is falling forwards. Her pelvic incidence is around 70 degrees. Her lumbar lordosis is around 38 degrees. She needs more around 30 degrees of lordosis. So there are 2 options here: either to do a big PSO from behind and do a big surgery, or in this case we did OLIF at L2, L3 and an ALIF at L5, S1, and we staged the procedure. With the staging, after stage 1 you can see the entire spine is kind of corrected. Her lordosis and thoracic spine, the kyphosis, it's all corrected. So we kind of decided that we can now actually do just percutaneous fixation and get the patient can be corrected with only a minimally invasive surgery, and we were able to save the levels in this patient. This is another patient, a 66 years male with severe back pain and bilateral lower limb. He was bedridden for 3 months. He was having difficulty in walking. If you see, his Cobb's angle is around 32 degrees, and obviously, as it was discussed before also, that D10 to S1 is the best way to go in these patients. So, but we kind of staged this patient, and this is what we got after stage 1. You can see just by putting the 3 cages, the entire spine got corrected, and we don't need to go from D10 to S2. We just need to kind of fuse it from L2 to L5, and we are able to save a lot of levels here. So this is one of the very important reason that by staging it also gives you that space, that with these powerful cages which actually corrects the coronal balance very well. So you might be able to save a lot of levels. This is another patient similar with the 30 degrees Cobb's angle. Again, staging was done. This is the, after the staging, stage 1, more or less the spine is corrected in this. So L1 to, this was immediate post-op. This was a bedridden patient. This is the post-op after stage 2. You can see we have been able to kind of save levels here also. Just the L1 to S1 fixation was done, and this was, he became independent walker after the surgery. This is another patient. I don't have a stage 1 surgery in between, but in this also, if you see that a conventional D10 to S1 fixation would have been required, but after staging we realized that a D10 to L4 fixation, we were able to save 2 levels, L4, L5 and L5 S1 here. So sometimes this can also help you in avoiding major osteotomies. This was a 52-year-old female with severe radicular and back pain for 2 years, had stooping posture with no neural deficit. Her pelvic incidence is 50 degree, lumbar lordosis is minus 20 degree, actually a kyphotic spine. You can see she is having a very rigid spine. Her SSA is 85 degrees here. This was, she is walking with a stoop, standing in a stooping posture. So we, just to get more and more lordosis anteriorly, we did a 4-level anterolateral OLIF from L2 to S1. But I was not able to get enough lordosis after the surgery as expected. I was expecting much more lordosis with this surgery, but I could gain just 10 to 15 degrees here. So a posterior procedure was added in this patient. We did multiple ponte osteotomy, and we were able to get a very good correction in this patient. We avoided a major pedicle subtraction osteotomy with the help of anterior cages. So sometimes staging helps you also to reduce the intensity of the surgery that is required posteriorly in these kinds of patients. This is the post-op of this patient, 1 year follow-up. She is doing very well. Sometimes in Shiza's grade D, this is a patient with L4, L5 lumbar canal stenosis with Shiza's grade D. This patient was also having rest pain, which is actually a contraindication for indirect decompression, where these indirect decompressions will not work. But because the anatomy was very well, because this was a severely stenotic, and we felt that if we could achieve some height here with anteriorly, it will be very easy for us to kind of do a posterior decompression here. Hence we staged this patient. We did a stage 1 OLIF in this patient at L4, L5, and this was the post-op MRI after stage 1. You can still see that the compression is still there, and we did a posterior, decompression. This is after the posterior MIS decompression of the same patient. So this helped us, getting the decompression done easily. This helped us also, because indirect decompression will not always work. Sometimes in Shiza's grade D, there are chances that you might not be able to, relieve the patient of those symptoms. So it is a good idea to stage those kinds of patients. We are not very sure. So maybe when it can be avoided when it is a straightforward case, when these are young patients or up to 3 levels you can put in lateral position. The timing is not going to increase. You can just finish the surgeries in 3 hours. Maybe those are the patients where you can do it in 1 stage. Or if indirect decompression or anterolateral decompression will not work in blocked or fused facets or fused spines, those are the cases where the staging is not required. So how to do it? This is a paper by Neil Anand who suggested putting in cages in all the lumbar spines which are going to come in the construct, fusing all those spines and using titanium rods. They are fusing it, and the dorsal spine, they are kind of fusing the facets, basically eroding the facets and putting BMPs there to fuse it. We are also using the same technique, and this is how we do it. So summary, stage surgery is a powerful tool. It can be used especially for elderly patients in 80 years old. It saves levels. It helps in reducing the extent of posterior surgery required sometimes. And sometimes it gives you a breathing space in complex situation and uncertain situation where you can kind of reassess the situation after your first stage. You can get your MRIs, you can get your X-rays done, and then you can do, or you can add a procedure posteriorly, a smaller procedure posteriorly, rather than doing a complete and extensive surgery posteriorly. Thank you.